and let's start living it together, because it's a much better way to go. We all seem to forget when it comes to diet and health, or diet and weight, that there's strength in unity. Most people who go on a diet leave their family behind. They abandon the potential strength and unity instead of saying, let's all eat better together because we love one another. Let's eat better together because we all want a long, healthy life to share. And you help me and I'll help you. And this could be spouse to spouse and parents to kids and kids to siblings and all of us, family, households. This is the way to get healthy, because there's strength in unity. We need to talk less about willpower, because nobody has the willpower to overcome what clever engineers are devising using functional MRI scans, and more about skill power. It's amazing what humans can learn. We all learned to ride a bike. It's a really challenging thing to do. We skinned our knees a few times, and then we had a skill for the rest of our lives. Most of us learned how to swim. Also challenging at first, but now we're safe in the water. There's a skill set for healthy eating in a modern world that makes it challenging. Some of us have it, most people don't. It can be shared, it can be taught. It ought to be routinely. And people can learn to love foods that love them back. If you've acclimated to a diet high in sugar, salt, and fat, you tend to prefer that. But if you slowly habituate to a diet of whole, wholesome foods, you awaken your comatose taste buds that require massive amounts of sugar or salt or other chemicals to be stimulated, and make them much more sensitive. I call that taste bud rehab. And it is the path for anybody, no matter how corrupted their palate has been, to learn to love the very foods that love them back. We also need to think about personalized nutrition more. We can't have one size fits all solutions. We're a multicultural society. You've heard of the DASH diet or the Mediterranean diet, but what if you're Mexican American or Chinese American or Vietnamese or Korean, or you just come from a part of the world where there's a distinct food heritage? Well, we can optimize nutrition in that lane, and that's what we ought to do. And there hasn't been nearly enough attention to that effort to date. And we should recognize the true promise of getting lifestyle right that can take us into the blue, which is so much better than what we're hoping to do with drugs and surgery. And I'm talking specifically about the blue zones, where people routinely live to be 100, do not get chronic disease or obesity, do not develop dementia. They live long, they prosper with vitality, they go gentle into that good night in the fullness of time. We know the remedy for all this in the realm of food. Michael Pollan got it down to 7 words: eat food, not too much, mostly plants. I've spent a career studying this. I concur. It took me many more words to say it, inevitably, as an academic publishing papers, 5,000 in this particular case, many more in my textbooks, but same basic conclusion. That is the theme of optimal nutrition for human beings. And that's the theme that prevails in the blue zone. So the blue zones are very diverse populations, 5 distinct regions of the world. You see them here on the map, from California to Japan and across Costa Rica and the Mediterranean, in both Italy and Greece. And if we plot their diets, which are very different from one another, on a scale from animal food predominant, ultra processed food predominant on the left in red, to plant food predominant, real food predominant on the right in green, dark green. Of course, the blue zones all cluster on the far right side of this slide. Plant food predominant diets, not all vegan, by the way. Some are, most are not, but they're all plant food predominant. They're all real food, mostly plants, every time. And this is not enough as we think about the fundamental problem of the food supply and the environment we live in. The problem extends well beyond our own skin. We have some hope of being healthy, vital people on a healthy, vital planet, or we have no hope of being healthy, vital people at all. And the diets that prevail in the modern world are cooking the planet. So as I make the case for diet as a vital sign, it's a vital sign for human health. Yes, it's also a vital sign for planetary health. So we're in a situation now where the Amazon is fast reaching a point of no return. You've heard this. This keeps me up at night. This is devastating news. And we could fix this, because as constitutional omnivores, we have choices. We can thrive on plant-exclusive diets. We can certainly thrive on plant-predominant diets. And we ought to be thinking about the implications of dietary choice, not just for our own health, but for that of the planet. And we have the option of a grand confluence where the way we eat is better for us and better for biodiversity and better for the planet. And this has been mapped out in the Eat Lancet Commission reports, and we're now awaiting Eat Lancet 2, which looks at food for both the health of people and the planet. if we dive down into this, get a little more granular, I especially like this paper. And if you're not familiar with it, this is another one I commend to your attention. Multiple Health and Environmental Impacts of Foods by a group at Oxford University. This is the one eye chart I'm sharing with you. I tend not to do this even to my academic audiences. I know some of my colleagues do, but I don't think people tend to like charts and graphs, so I stay away from them. But this one's worth a quick look. So in A, at the top, you have a set of conditions affecting humans, including death and cardiovascular disease and colorectal cancer. And then along the side, you have foods and their impact on those conditions, going from whole grains down to olive oil and everything in between. Green is good, red is bad. The other colors are intermediate. In B, down at the bottom, we have another set of outcomes, but these are planetary health outcomes. So acidification, eutrophication, which is nitrogen use, greenhouse gas emissions, land use, water use, the same foods. And once again, green is good, red is bad, other colors intermediate. So there's the eye chart. The paper that I shared is this detailed, but we can sum it all up as they do in the paper, looking at two simple axes: the risk of human mortality on the x-axis here, so it's worse as you move to the right, better as you go to the left, and on the y-axis, adverse impacts on the planet, better down at the bottom, worse at the top. So the bottom left corner is the good place to be. Everything in green is nearest the bottom left corner, and guess what's there? Vegetables, fruits, whole grains, beans, lentils, nuts, and seeds, the usual suspects, the stuff we already knew we should eat more of. And look at what's doing the most damage to both humans and the planet: processed meat and red meat, way up in the upper right-hand corner. So we can get this right for ourselves, and we can get this right for the planet. And all this argues that it's a vital sign for both. So the sweet spot is best diets for us, best diets for everything else down here. And by the way, kinder and gentler to the rest of biodiversity. So we get diet right. It's better for domestic animals. It's better for wild animals that need wild ecosystems to call home. It preserves rainforests. It preserves aquifers, and it adds years to lives and life to years. I pivot now, and I'd like to think I'm still minding my business by talking about what I do now to address this. So I've made the case that diet ought to be a vital sign for the sake of human health, for the sake of planetary health, for the sake of curbing epidemic obesity and getting at the root causes of that, the pandemic of chronic disease, the acute effects of SARS-CoV-2. All of those are reasons why diet should be a vital sign. Another comes to us from the realm of business, this aphorism: we manage what we measure. But it's true in medicine too, where what matters most we call vital signs. We measure it routinely and we treat to goal. Well, if diet quality is the single leading predictor of all-cause mortality, premature death, and total chronic disease risk, it obviously matters enough that we ought to manage it. And if we want to manage it, we probably need to measure it. So this has motivated a major change in my career. I've been an academic physician at Yale for much of my career. I fully left academic medicine to become an entrepreneur, much to my surprise, in 2019, because in 2016, I invented something that seemed to me to be important enough to justify that. And I founded a company and have been running that. And that company was acquired by a food as medicine company last year. I want to talk about what we're doing and why we're doing it, because we believe we manage what we measure. And so in medicine, think about the blood pressure cuff. There was a world before the invention of the blood pressure cuff. We already knew that blood pressure was very important. People in the health sciences already knew blood pressure was a major predictor of heart attack or stroke. And we could measure blood pressure. It was just extremely painful and inconvenient. It required intra-arterial catheters, which frankly hurt like hell. So they were rarely used, of course. They weren't scalable. So in most people, we didn't know their blood pressure, but we knew blood pressure was important. So guess how we knew blood pressure was broken? A heart attack or stroke or blindness or kidney failure. We basically waited for bad effects of blood pressure and they said, you've had kidney failure, you must have hypertension. That's bad. Maybe we can try to do something about it. And they didn't, of course, didn't have very good things to do about it either. So we were never upstream of the problem before the invention of the blood pressure cuff. We always waited for calamitous effects and then reacted. The blood pressure cuff changed that. It took a while. But when everybody's blood pressure was measured, we were now upstream of the problem. And guess what happened? We started developing population norms for blood pressure. We started identifying appropriate targets. And everybody in medicine, everybody in healthcare who knew nothing about managing hypertension needed to learn. It became a priority. It became a standard of care. It became a measure of the quality of prevailing clinical practice. And it led to all sorts of innovation spanning pharmacotherapy and lifestyle interventions. The DASH diet, we would have no DASH diet if we didn't have the blood pressure cuff. We manage what we measure. So what I've been involved in for these past years takes this into the realm of nutrition. I already showed you this op-ed earlier in the slide deck, Our Food is Killing Too Many of Us. I won't reiterate what they found, except to note that when they continued their argument in the op-ed, they didn't just talk about the scope of the problem, 500,000 premature deaths. They started talking about what we ought to do about it. And the first thing they mentioned is that hospitals should include a measure of nutrition in everybody's electronic health record. And here. And the American College of Cardiology, American Heart Association have adopted the formal position that diet is of such outsized importance in cardiovascular medicine that it ought to be measured at every encounter. If only we had a tool that made that possible, which when this was published, they didn't realize we did, because for decades we have not. And the reasons we didn't have a suitable tool are just like the reasons we couldn't use an intra-arterial catheter in everybody. It was too painful, too dangerous, too costly, just too onerous. Well, that's where we are with diet. So we can do multiple 24-hour recalls where you take roughly 20 to 30 minutes to try and remember exactly what you ate yesterday. And we need at least 3 different days because one day tends not to be at all reliable. Or you can take 90 minutes to 2 hours to complete a semi-quantitative food frequency questionnaire. How often in the past 3 to 6 months did you have donuts or French fries or broccoli, and how much, and what did you eat it with, how much of that? As you can infer, nobody can remember all those details, absolutely nobody. Or you can journal everything you've eaten for the span of 3 days or 7 days and submit that to a dietitian for an N of 1 analysis. And this is all rather like an intra-arterial catheter. It's expensive, it's inconvenient, it's at the N of 1 level, it's simply not scalable. It's not the answer the American College of Cardiology was looking for. So I invented something that is the answer that they were looking for. By the way, it's incredibly simple and yet powerful. So what you're seeing here on the far left is a phoropter, and any of you who's ever been to the eye doctor has used this device. The device is pretty intimidating, right? I mean, you look at that and think, wow, a lot of engineering went into that thing. You'd be right, lots of optics and physics. But our use of the device as the patient is unbelievably simple. Basically, it shows us 2 images at a time, and it's our job to say which is more in focus. So you look at the balloons, and pretty obvious to all of us that the bottom balloons are more in focus than the top. It's usually side by side, and you pick one, and then the tech or optometrist or ophthalmologist says, how about now, and shows us 2 more images, and we play the game until we have an exact match for our visual correction in units, diopter, so it's quantitative. Well, we invented this for diet. Rather than asking people to badly misremember exactly how much of exactly what they've eaten over some span of time, we said the goal of all of that is to put together a representation of their overall dietary pattern. What if we just do that? What if we build a diet map? Diet type on the x-axis, diet quality on the y. Every cell in the map is a particular kind of diet, paleo and keto and low carb and Mediterranean and flexitarian and pescatarian and vegetarian and vegan and Korean and Vietnamese and Mexican and Cuban and at 10 tiers of quality. So every cell is a particular type of diet at a particular tier of quality. We'll have our dietitians build out a multi-day meal plan that matches the specs for that kind of diet at that tier of quality. We'll turn that multi-day meal plan into an image. We'll shrink that image down to the irreducible minimum so we can show you 2 at a time on a smartphone screen and ask you, which of these looks more like stuff you eat, A or B? And play that game for about 60 seconds until we've got you. And that's what I've been doing for the past years. I've been privileged along the way to work with some of the best in nutrition. Those of you who watch Netflix probably know my good friend Christopher Gardner at Stanford. He's the principal investigator of the You Are What You Eat special featured there. I suspect most of you know Walter Willett, former chair of nutrition at Harvard, and you may know some of the others here too. Luminaries all. David Jenkins invented the glycemic index. So we worked together for years, built out the diet map, and introduced a whole new way to measure diet as a vital sign. Give us a digital interface, a smartphone, a computer, an iPad, anything, and give us about 60 seconds, and we can do a comprehensive dietary assessment that gives us diet type, an objective measure of diet quality using the Healthy Eating Index 2020. So again, if you think about the phoropter, it produces a measure of the correction of your eyes. In diopters, it's quantitative. You think about the blood pressure cuff, it's not loosey-goosey, it's not kind of, sort of. It's units, millimeters of mercury, systolic pressure, millimeters of mercury, diastolic pressure. It's quantitative, it's actionable. So that's what we're doing for diet. A measure on a 1 to 100 scale, the Healthy Eating Index. And we also know servings per day of all the different food groups, units per day of over 200 nutrients. So we're basically on a mission to make diet quality a vital sign. And we say that diet ID is to diet as the blood pressure cuff is to blood pressure. It's a way to measure this thing that needs to be managed at the population level. And again, your experience on the screen would be something like this. We would ask you some questions at the beginning. So if you're vegan, we don't show you pictures with animal foods in them. If you eat a typical American diet, we do. If you have a cultural diet, we show you that. But either way, we show you 2 cells from the map in the part of the map you're in and ask which looks more like stuff you eat, A or B. And you just pick one. And then we say, how about now? And you pick one. And we say, how about now? We remind you of what your former choice was. We play the game until we've got you, often in as little as 60 seconds, almost never in more than 3 minutes. Then we right size it for you, and we can instantaneously report back your diet type, your diet quality, and the details of your food and nutrient intake. So we're taking 90 minutes and reducing it by roughly 2 orders of magnitude to 1 minute. And then we can do all sorts of great things when we have this detailed information. We can use what we know about your baseline diet to go to a personalized version of your goal diet. You think about how GPS works, by the way. In order to give you a turn list, it needs to know both where you are and where you're going. We almost never have that information about nutrition. A detailed assessment of where your diet is and a comparably detailed assessment of where your diet ought to be. Not ought to be because someone's wagging their finger at you, but ought to be because you've got objectives. You want to lose weight or manage your blood pressure, improve your diabetes, or whatever it were. Optimize athletic performance, improve your cognition, reduce inflammation, whatever it is. We invite people to pick all that pertain. We ask them to tell us if they've got a cultural diet they want to maintain, or if they have a dietary pattern like being vegan or vegetarian that they want to maintain. And we then identify a goal diet. We can directly compare the baseline diet to the goal diet and get that down to differences in servings per day and units of nutrients. And then we provide behavioral support that isn't generic. It's not, here's how to eat better, but rather, here's the specific sequence of adjustments you can make to your specific diet to get from where you are to where you want to be. That's truly personalized nutrition. And we call it behavioral navigation. It's not behavior modification. It's not, your behavior is wrong, we're here to fix it. It's, you've said where you are. You've said where you want to go, just like GPS. GPS doesn't tell you where to go. You tell it where you want to go, but it helps you get there. That's what behavior change ought to be. Behavioral support, behavioral navigation. What's the sequence of changes I need to make to my diet to incrementally move me in the direction toward my destination, the diet I want to have? So that's what we've put together. And very important to me and very important to the team is that it's multicultural. So if you're Mexican American and you have hypertension, we don't say the DASH diet, good luck. We say, we recommend a high quality version of a Mexican American diet, which, by the way, has the same sodium content, calcium and potassium and magnesium and fiber and all the rest as the DASH diet. And it leaves you in the lane you want to be in. It honors your culture, your heritage, your upbringing, your dietary preferences, and puts you in a position where you can love the foods that love you back. And the set of cultural diets in the map is growing all the time. We have many more than shown here, but this is the idea that you can develop very high quality versions of all sorts of different diets, Mexican, Indian, Caribbean, South American, and so forth. So we do that. And then for clinicians, this provides a comprehensive dashboard. And we're hoping that we can help address the deficiency of nutrition education medicine by providing this level of detail and translating it into, for this given patient, here are the nutrients that most need attention. Here are the food changes that most need attention. Here's how you can, in a limited amount of time, make the biggest difference. So we develop a comprehensive dashboard. And of course, I'm a research scientist. Most of my career has been in clinical research. So we've extensively validated this against all the prevailing instruments, food frequency questionnaire, 24-hour week, all these are publications in the peer-reviewed literature. We've validated this against biomarkers. We've deployed into federally funded studies all around the country at major universities. This is a truncated list. And there's yet one more advantage of this. When I talked about the GLP-1s, I mentioned, excuse me, Lots of talking. I mentioned that the cost is my biggest concern. So here, and I see there's a hand raised. I'm nearing the end, and we'll take questions after. Here, so Hannah, just remember your question, please. Um, the the issue with diet quality is that it's upstream of changes in biomarkers. It's upstream of chronic disease. It's upstream of bad outcomes. And when you move upstream, you have greater opportunity to make a difference. But one of the things you need to know if you're going to justify food as medicine interventions is how can you pay for them? What are you going to do to the bottom line? So yeah, okay, this is great. We're adding years to life and life to years, but what's the cost? Well, we published a paper in the American Journal of Health Promotion getting at that issue because there's a very strong case in the peer-reviewed literature that when you improve objectively measured diet quality, you can save a lot of money. The average annual per capita cost of obesity versus not is about $2,000. The average annual per capita cost of hypertension versus not is about $2,000. The average annual per capita cost of type 2 diabetes versus not is about $10,000. The average annual per capita cost of symptomatic coronary disease versus not is about $25,000. And in fact, with GLP-1s, all these costs are going to go up. So you don't need to prevent a lot of this stuff to save a ton of money, much more than you need to spend to introduce a food as medicine intervention for a population. So we built an interactive ROI calculator for food as medicine. If any of you are involved in population health efforts and are working to advance food as medicine interventions, and you want to be able to get ahead of what the financials would be, you're very welcome to use this calculator. It's in the public domain. You go to dietid.com. At the top on the marquee, there's science. Just hover over science, scroll down to ROI calculator, and you can plug in the numbers, and you can generate projections about financial savings and a return on investment for any given population. But this allows us to get upstream where we have the greatest potential to do good, but we also have incredible potential to do well because a lot of money can be saved by taking this approach. One final thing with regard to what we're working on, and then I'll be very happy to take your questions. We noticed earlier, remember some of the people that I was working with when we developed this innovation, Walter Willett, David Jenkins, people who are passionate about the health of the planet. Walter is one of the principals in the Eat Lancet Commission work. So all about diet to optimize both human and planetary health. Well, we noticed the way we had put our map together, a fairly obvious gradient in environmental impact because we put diets from animal food centric on the left. So we put paleo and keto way over on the left to plant food exclusive all the way on the right. So the vegan diets are over there. And we put low quality diets at the bottom and high quality diets at the top. So we noticed, well, if you go from bottom left to top right, you're going from animal food predominant and bad, highly processed, to upper right, plant food predominant, plant food exclusive, and high quality, massive environmental impact gradient. What if we created a quantitative measure of that so we could tell people here are the different diets that would satisfy your health objectives? And on a scale of 1 to 10, here are their environmental footprints. Would you like to choose the one that's best for you and the planet? We call this project Diem, as in Carpe Diem, seize the day, because we're running out of time to save our planet as well as ourselves, but also because it's an acronym, Dietary Impacts on Environmental Measures. We've been privileged to work with two leading experts in the environmental impacts of foods, Guidon Echel and Marty Heller, and we've had the help of a postdoc at Harvard, Marie Januszewski. We've been working on this for a while. So we're looking at 4 discrete measures of environmental impact: greenhouse gas emission, land use, water use, and nitrogen use. We're looking at those quantitatively at the level of individual foods, building that up into an aggregate to represent the impact of overall dietary patterns, putting it on a 10-point scale and appifying it so we can say, here's your diet now. Here are the diets that are good for your health objectives. Here are their environmental impact scores. And can we perhaps invite you to choose a diet that's best for you on the planet alike? We'll be introducing this in app form before the end of the year. It's currently in production. So carpe diem indeed, because for a long time, obviously, we've been wrestling with the adverse effects of food, and we've had the weight of our patients' health problems to carry, the obesity pandemic, the chronic disease pandemic. But our problem now extends beyond this. We really have the weight of the world on our shoulders because ecosystems and rainforests and glaciers and aquifers and biodiversity are at stake. And as I said earlier, we have some hope of being healthy, vital people on a healthy, vital planet, or we have no hope of being healthy, vital people. So it is for the sake of healthy people on a healthy planet that the evidence all suggests diet quality should indeed be a vital sign. And now we can make it so. And with that, Michael, everybody, I thank you so much for your time and attention. And I'm very happy to open this up for questions.
Thank you so much, Dr. Katz. That was some great information. So real quickly, how would people get in touch with you if they wanted to follow your work?
Said a earbud cut out on me. I have a personal website, davidkatzmd.com. I don't know that I've done a terrific job of keeping it fully current, frankly, but you can certainly find me there. My contact information's there. I'm on LinkedIn. I'm pretty easy to find. And people are welcome to email me. I have multiple email addresses. The one that is sort of public facing would be my Gmail account, davkatz7@gmail.com. Happy to follow up. There are other ways to reach me, but that should suffice.
And people interested in checking out Dr. Katz's books can find them on the realtruthabout.health.com website. And you'll purchase it through Amazon, but we'll get a little bit of money to help fund what we're doing here at The Real Truth About Health. And just real quickly, because I'm seeing something in the chat that some people try to check out your diet ID. And they were saying that it's only available through an organization rather than through an individual. Is that correct? Is there any way for an individual to check that
Yeah,
out?
it's actually one of the reasons I felt comfortable talking to you about it because I'm not selling it to you. So we're not in the App Store. So we if you think about it, you don't have to buy a blood pressure cuff. You can. They're home blood pressure cuffs, and if you want to monitor your blood pressure, you can. But your opportunity to have your blood pressure checked comes to you, right? It's hard to avoid. Anytime you have a medical encounter, your blood pressure gets checked. We feel that's how it ought to be with diet quality. It's actionable. It's information you should have, just like your blood pressure, but you shouldn't have to subscribe to something. So we're a B2B company. We license to health systems. We license to health professionals. However, I also support the interest you may have. Gee, I'd love to get a comprehensive assessment of my diet. You can reach out. There's a contact on the Diet ID website, dietid.com, and my team will respond to you. But the other thing is, if that idea that if you agree, diet quality should be a vital sign, um, whoever is responsible for your healthcare, let them know and let them know about us, because we license to clinical practices. It could be as small as a solo practice. So we can make this available to all the patients of a health coach, a dietitian, or a physician. So if you're interacting with anybody in the health system and you'd like access to this, let them know, and then they can secure that access for you.
Thank you so much. So we're going to begin the Q&A portion of our time together. For the audience, if you'd like to ask a question, you can raise your hand in Zoom. The instructions are in the chat. So real quickly about this, this product, people are notorious for lying to obviously other people, but also to themselves about how healthy.
Right.
How does your app try to avoid that tendency that people have to do so?
Exactly. And we have evidence that it works. So if you think about it, and by the way, we can be brutally honest with one another and still be compassionate. So yeah, we tend to lie to one another and to ourselves, but these are little white lies, right? I mean, so when you ask somebody how often they've had donuts in the past 6 months, it's not necessarily on purpose that they're going to underestimate their donut intake or French fry intake. And when we ask, how much broccoli, it's not necessarily on purpose that they're going to overstate that a little bit. It's just, we basically are trying to be virtuous, and, we'd like to spin the story in a favorable direction. It's just human nature. It's perfectly fine. But if you think about it, that tendency is amplified when you're going food by food, because every answer to every question is an opportunity to distort. So every time we ask about the so-called bad foods, people are going to underestimate. And every time we ask about a good food, they're going to overestimate. We're aggregating error after error after error. What we've done, we don't eliminate the potential for some distortion, but we mostly do, because we give you a dichotomous choice. Which looks more like what you eat, A or B? So you either have to tell a big whopper of a lie. I know it's A and I'm going to say B. That's hard to do. That produces what's called cognitive dissonance. You're trying to get at an honest conclusion, and you're confronted with the option to tell a lie you know is a lie. And people don't tend to do that. Only genuinely dishonest people do that. So most of us don't do that. And so operationally, we know we had a defense against that tendency to distort. And then we have evidence that it works, because when we've compared ourselves to food frequency questionnaire and 24-hour recall, there's robust correlation, but it's far from perfect. And what we find is diet ID tends to generate a lower diet quality measure than the food by food measures, where those distortions all add up. We tend to generate a higher estimate of calorie intake. So we have all sorts of indications that although we correlate robustly with those past tedious measures, we're correcting their errors. All the differences between the diet ID approach and the prior approaches point in the direction of us fixing those errors. The only way, to perfectly control the information you get is to put people on metabolic wards. And even that doesn't really work, because people eat differently on metabolic wards than they eat in the real world, right? So there's no definitive solution to this problem of the potential for distortion, but we think we've substantially corrected it. And it's clearly more than good enough, because we have evidence that variation in our measures of diet quality track very robustly with variations in biomarkers, variations with markers of dietary intake, variations in BMI, all the things you would expect if the measure is really working. So we're confident it's really working.